because the toxo IgG was positive. Mind well, in HIV, toxo IgG is having a negative predictive value. If it is positive, it doesn't tell you the diagnosis of, doesn't support the diagnosis. It just supports but doesn't confirm the diagnosis. So what we have done is, after the patient has come back and he has fortunately not stopped anti-TB and anti-toxo both, we have done the toxo IVDT test. And to my surprise, the IVDT in this patient was 60%. So there was no question of having an active toxoplasma. We have stopped his anti-toxo and he has continued, and after 1 year now, his lesion is in the brain as well as fever has gone. Otherwise, we should have diarrhea, malaria, and whatever the normal things we should also suspect in HIV. Another thing is, again, the malignancies, age defining as well as non-age defining. This male, 32 years old, was already on ART from 2009. He had tenofovir, lamivudine, efavirenz as a drugs, and he came to us in December 20, and he was already on drugs, but he said that he has lost 12 kgs and his USG was repeated 2 times. We went ahead with the CT of abdomen. It was showing multiple parotid lymph nodes. We went for a FNAC. FNAC was negative. Patient was continued to have fever. Ultimately, we have done a laparoscopic biopsy in that patient and it turned out to be Hodgkin. So you have to just continuously think about it. So don't leave the patient like that. So POA is important in HIV. Presentations in 2 to 3%. In pre-heart is about 10%. Around 2 to 3/3 have a CD4 count of less than 50. 60% of the result from the infection. Always remember about the iris. Multiple etiologies may exist, but HIV alone will not be the cause. But if you go to patient, doctors ask every day, how are you, my dear? How is your fever? He says, fine. And then he gets a dream and says, and the happy trees say, my hallucinations have stopped. This history and examination, everything has been covered by Dr. Patil sir. And thank you very much.
Thank you for a very comprehensive lecture, Dr. Milind, and you completed well in time. We are running short of time, and there are instructions that if questions would be at the end of the session.
I request Dr. Joshi sir and Dr. Bora sir to felicitate Dr. Milind Burshande sir with memento and floral bouquet.
The last speaker in this session is a critical care specialist, Dr. Rajan Barokar, and he'll be speaking of nosocomial FEO or FEO specifically related to ICU.
Respected Dr. Rathod sir, organizing chairman, my friend Dr. Deepak Agrawal, secretary, Dr. Wag sir, Vidarbha API president Dr. Mishra sir, and all my senior colleagues, my teachers. First of all, I thank Vapicon organizing committee for giving me this opportunity to come over here and speak on fever in intensive care unit. Well, definition of fever general is already been given by Dr. S.M. Patil. Sir, I just wanted to emphasize on that. When we talk about fever, we don't talk about a temperature of 98.7 or 99 or 100. When we are speaking about fever in ICU, we are talking about a temperature of more than 101 degrees Fahrenheit. That is 98.3 degrees, 38.3 degrees centigrade. So it is reasonable in many ICUs to consider everyone with a temperature of 38.3 degrees centigrade to be febrile, and this warrants special attention to determine whether this is infection or something else. Well, as the mechanism has already been told by Patil sir, this is preserved phylogenetic response to and to a wide variety of infections and non-infectious triggers. So if you look at this, can I have a pointer please? So if you look at this mechanism, there are different methods by which body gives fever. One is directly by inflammation, where there is a different pathway. There is an autonomic pathway which takes care of that inflammatory fever. And if it is an infective fever, there is an exogenous pyrogenic response, and which leads to liberation of endogenous pyrogens, ultimately leading to prostaglandin E2 release and subsequently giving rise to fever. So the mechanisms are different. Inflammatory fever is different, infective fever is different. And in ICU, we do get both types of fevers. Now when we talk about fever, we always get panic, especially relatives. आज भी फीवर आया क्या, पेशेंट अभी 6 दिन हो गए, अभी तो फीवर नहीं था, आज एकदम सडनली फीवर कैसे आ गया. These are their questions. Then you say, okay, this might be because of lines, this may not be because of infection. Then their second question is, when will this fever go off? When will patient become afebrile? Then another 5-6 days, patient still continues to get 100 fever. Some staff nurse, some resident doctor tells relatives, no, your patient is still getting fever. Kitna hai? तो 99.5 है या 100 है. Again the relatives, they come to you in counseling. They say, doctor, he is still getting fever. Then it becomes extremely difficult for you to tell them, emphasize that this fever is not an infective fever. This is an inflammatory fever. Don't worry about that. We are keeping an eye on that. So we want to tell them that getting a fever is also a good sign at times. Or rather, most of the times, getting a fever is a good sign. And why? This because the fever is carrying these beneficial effects. First is on invading microorganisms. It reduces the growth of microorganisms. It prolongs the growth time of microorganisms. Second is it increases the antibiotic sensitivity. Having a body temperature high, there are many studies which has been carried out by increasing the body temperature of an animals like rats and pigs. And they have found that those animals which were having an increased body temperature had a better immunomodulatory response, and they responded better to these infections which were there induced in their body. And another thing is the antibiotic MICs used to be very low, or the required MICs were very low in the patients who used to have a fever than those who did not have fever. Second is there is an accelerated immune response in the patients who gets fever. And third is there is a protection against the collateral damage if this patient is running fever. But then there are detrimental effects. Now its detrimental effects are broadly present into two categories. One is the patients who have a neurological problems. Patient who has a primary brain injuries. In those patients, if they get fever, they can subject themselves to a secondary brain injury, which will be detrimental in this. And second category of patient is the patients who are of a cardiac problems. The patients who already has a compromised LV functions, and if those patients, they get trigers, if those patients, they get tachycardia, they get high-grade fever, their metabolic demands will increase, their heart rate will increase, and then naturally they will have more problems because of their increased metabolic activity. Second is maybe in children, those who have a seizures. This is little bit controversial. And then there can be a collateral tissue damage if these patients have a high-grade fever. So the detrimental effect of a fever does not come unless this temperature goes into moderate to high degrees. That is not up to 101 degrees, but if it crosses 102, 103, 104, then probably they have a detrimental effect on their body. Well, this is another nice article or commentary which I have found, that the question which is asked is the continued question of how fever duration is associated with patient outcome. And in that, they have mentioned there is a possible association between fever duration and mortality. But then when they say that, they also defend that the direct correlation is yet to be proved. Then they also say that the persistent fever in specific patient groups, mainly those with cerebral damage or limited cardiorespiratory reserve, could probably lead to worsened outcomes. So these things are not absolutely proved, but these are postulated that in all the patients who develop fever or who get fever, those who have a neurological problems or those who have a cardiac problem probably develops has a worse outcome than those who do not have those fall into this category. Then this was another clinical review which has come into critical care journal. Fever in septic ICU patient, is it a friend or foe? There are enough evidences that fever is not always a foe. It is most of the time it is friend, because it's a fever which would alert us to something wrong which is happening into patient's body, some additional infection which has entered into the patient's body. So that is why the fever is must. Fever, if it is not present, likewise in patients with an immunocompromised state, neutropenic state, in an old age group, the patients who are on steroids, these patients will not get fever, and many times by the time you detect the infection or the progress of a sepsis or septic shock, it's a late. So I think fever is more of a friend. The balance of benefit to harm of fever in septic ICU patients is complex, and it depends on, one, the stage and severity of the infection, two, on the intensity of the immune response from the patient's body, three, extent of systemic inflammatory response induced collateral tissue damage, and four, the underlying physiological reserve. As all of you are aware of, all ICU patients, when we talk about the outcome in ICU patients, first and foremost thing we look into is their comorbidities, their basic physiological reserve. If somebody who is sick since long time, since years together, somebody who has a collagen vascular disease or already immune compromised state, they do not have a good physiological reserve, and outcome in these patients would be much, much worse than those who do not have that. Now, when we measure temperature into ICU, there are many times the errors which are committed. So, some people, they take a temperature into the axilla, few people put a temperature thermometer into their mouth, few people measure temperature when there are ice pads already applied into the axilla and temperature probe is over there. Few of them, they measure it from the rectum by putting a thermometer into it. Then there are transducers which come, electronic transducers which can be put, and other methods like thermodilution catheters by which we can measure temperature, and even esophageal probes. Out of all, then even tympanic membrane also. Abroad in US, they used to measure the temperature through a tympanic membrane probe. But all of this, which one is more reliable? So in the decreasing order of importance, we can say the most accurate ones are those with the pulmonary artery thermistor. They are the most accurate. Bladder temperature, the catheter which is thermistor which is inserted through the catheter, probably that is most accurate. Then esophageal probe, and last is the rectal probe. Axillary probes over the tongue, they are not that reliable. I think I already finished the 10 minutes. Well, about this management of fever, there are definite guidelines which evaluate the new fever in critical ill adult patient. These are 2008 guidelines by SCCM. These are few infectious causes and non-infectious causes. The commonest one being the bacteremias, catheter-related bloodstream infections, surgical site infections, or in a perioperative patient inside at a surgical places. Then ventilator-associated pneumonia in ICUs. There are n number of other causes also are there, infectious causes which one needs to look into, especially endocarditis, meningitis, pseudomembranous colitis because the patients are on antibiotics, suppurative thrombophlebitis, and urinary tract infections. When we come to non-infectious causes in ICU, there are a list of non-infectious causes, but I would just enumerate the important ones being the acalculous cholecystitis, adrenal insufficiency, deep vein thrombosis, drug fever, thyroid storm, and transfusion reaction. Transfusions are something which are very common in ICUs. They require plasma, they require blood, they require other blood products, and every now and then after transfusion, the patients, they get fever. So most of the times, transfusion is one of the major culprit. Another, acalculous cholecystitis, although it is being mentioned as an important cause, I won't put that as a most important ones because we haven't seen more of or much of an acalculous cholecystitis. Drug fever is common. And on this side of a list, well, there are places like thromboembolic diseases, vasculitis, which are also equally common. as a non-infectious reasons. This is just a list of non-infectious causes in which blood transfusions, a calculus cholecystitis, venous thromboembolism, patients who are on dialysis, especially after finishing dialysis, these patients develop fever. You need to keep that into mind. Then patients with an IV cannulas, like Professor has rightly said, you need to see whether after flushing the catheters, patient is getting rigors, patient is getting fever, or there is a fall in blood pressure. Those are the times when you need to change the catheters. This was one of the study which compared risk factors and outcomes for prolonged versus brief fever in ICU. There are patients in which the most common causes of prolonged fever. Prolonged means the patients when they get a fever for more than 5 days in ICU. Fever for 1 or 2 days is fine, subsequently it goes off. But those patients in whom the fever remains there for more than 5 days, the most important reasons are probably of ventilator-associated pneumonias, urinary tract infections, catheter-related infections, intra-abdominal infections. Then, once your patients they develop fever, you need to rule out the reasons whether this is infectious or non-infectious. There are few biomarkers which would guide you whether this is a bacterial or non-bacterial infections, like C-reactive proteins, procalcitonin. Procalcitonin has a very good prognosticating value. So if you do a sequential serial procalcitonin or CRP levels, you can actually decide whether you need to continue antibiotics in these patients or you need to stop antibiotics in these patients. So many times antibiotic therapy is guided by the biomarkers. This is just a clinical case which has come to my ICU last week, who was a gentleman, father of a critical care consultant, who had a fever since last 4 weeks, and then his X-ray and CT chest was like that. He had a bilateral heterogeneous opacities all over lung. He had a pleural effusion. He had a thyroid nodule. We did an FNAC. We got a fluid, everything from there. All was non-conclusive. There were no organisms which we could get from this. But subsequently, when this bronchoalveolar lavage was done bronchoscopically, that is where we got a PCR done, and then we got a tubercular positive. And the patient was put on antitubercular agents along with steroid, as again the fever of 100 degrees Fahrenheit was a major concern over there. Although patient was clinically better, clinically well, but that fever which was persistent, that need to be stopped with this addition of steroid. So lastly, if you want to approach a fever in ICU, first and foremost is you need to do investigations, investigate those patients thoroughly, take a help of biomarkers. When you are sending an investigations in from ICU to a lab, see to it that there is no contamination of blood culture, urine culture, sputum culture, because the collection is also very important. Remember, all catheters, tubes, lines, drains, you need to get rid of them as soon as possible, as early as possible. Believe in general nursing care, emphasis more on nursing care, especially care of mouth, care of various sinuses, care of perineum. Then remember, non-infectious causes also in a patient who is in ICU. Sometimes the history is not properly taken, and many times it is missed. Then repeated thorough clinical examination cannot be underemphasized. It's always very, very, very important. And lastly, you must think again. Fever is not always bad, it's good also. And lastly, we must always thank God when you are relieved of this feverish nightmare in your ICU. Because that's one thing which your patient पूर्ण चांगला होऊन जातो, चालायला लागतो, सगळं राहतं, पण सर अजून तापच नाही गेला. अजूनही मधनं ताप येतो, अंग गरम लागतं. These are the patient's relatives' complaint. And you are really happy when patient becomes febrile. Thank you very much.
Thank you, sir. I request Dr. Joshi sir and Dr. Bora sir to felicitate Dr. Barokar sir. Poster and abstract presentation is arranged at lecture hall. Interested delegates can move to lecture hall.
So we have another lecture on infections. It is by Dr. Mahesh Abhyankar, who is going to speak on a very common problem of malaria. We had 4 very good lectures, talks on pyrexia of unknown origin. All the 4 experts spoke very well on the different aspects of pyrexia of unknown origin and how difficult it is many times to diagnose pyrexia of unknown origin and think of infectious and non-infectious etiologies as well. Dr. Abhyankar is ready now, please.
Good afternoon to all the clinical experts. I'm going to talk about a very common topic. I think every doctor is managing malaria. We have discussed a lot of causes of fever of unknown origin in the last 4 speeches. But when it comes to a simple fever in the clinical practice, today it is becoming a very important problem because it's a clinical dilemma. Because there are so many different infections, starting from bacterial infection, viral, malaria, dengue, leptospirosis, tuberculosis. All are basically either somewhere from food and water, or from air, or from vectors. A mosquito is one of the very important vector. In the Bollywood, Nana Patekar was one of the person who has made mosquito popular by his famous line, "Ek machhar aadmi ko hijra bana deta hai." And the most recent is basically the king of romance died because of mosquito bite. The mosquito may be different, but yes, when it comes to malaria, there is a triad. One is agent, 4 Plasmodium species, out of that Vivax and Falciparum most important, but now you are already aware that there is a 5th species already present in the human beings, that is Plasmodium knowlesi, which is already there in the Malaysian region. It has not entered still into India. Vector is Anopheles mosquito female. In India, almost 45 subspecies are present, and the host is human beings. Now the government talks about 2 million patients of malaria in India. But I think no private doctor reports any kind of patients, and today the private practice is 80 to 90%. So the malarial cases are too high. It's almost 20 times than the government record. And many times patient comes with fever, we give anti-malarial drugs and the patient respond. Now those kind of patients were also maybe suffering from malaria. But the issue in India is rising falciparum. There's a